today about Hirschsprung disease. Hirschsprung disease is a congenital condition that affects a large intestine, colon, and causes problems with passing stool. Pathophysiology of Hirschsprung disease involves a failure of neural crest cells to migrate properly during fetal development, resulting in the absence of entering ganglia in the segment of the colon. How do we diagnose Hirschsprung disease? Diagnosing of Hirschsprung disease involves a combination of clinical evaluation, radiological imaging, and definitive histopathological confirmation. Welcome today about Hirschsprung disease. Hirschsprung disease is a congenital condition that affects a large intestine, colon, and causes problems with passing stool. It's caused by the absence of nerve cells that are called ganglion cells in a portion of the colon, which results in a blockage and difficulty with bowel movement. Pathophysiology of Hirschsprung disease involves a failure of neural crest cells to migrate properly during fetal development, resulting in the absence of entering ganglia in the segment of the colon. It sounds very complicated, so let me explain what neural crests are. Neural crest cells are very specialized cells that originate from the outermost layer of the embryo that is called ectoderm during the early development. They are highly migratory and multipotent cells, which means that they can become many different types of cells. For example, they may become part of the nervous central nervous system. They may become part of ganglion cells in the gut. They may differentiate to melanocytes, which is a pigment in the skin, or craniofacial structures like bones and teeth, or they can become a part of the cardiovascular system. In Hirschsprung disease, these cells fail to migrate completely or properly to the distal part of the colon, rectum, and sometimes extending to the sigmoid colon or even further. And the affected segment lacks both mesenteric, so in the smooth muscle of the gut, and ganglion cells. The absence disrupts the coordinated peristaltic activity that is required for bowel movement. The aganglionic segment, so segment that is lacking those nerve cells of the colon, is unable to completely relax, leading to a constant state of contraction. As a result, there is a buildup of the fecal material proximal to the aganglionic segment, causing distension, which is called megacolon, and potential bowel obstruction. The normal innervated segments proximal to aganglionic part becomes hypertrophic and very dilated, and this is because of the buildup of the fecal material and those normal proximal segments trying to push the fecal content through the narrowed and obstructed segment. What is the clinical presentation? What are the symptoms of babies that have Hirschsprung disease? First of all, first symptom, delayed meconium passage. Most healthy newborns pass their first stool, that is called meconium, very thick, green, dark stool, within first 24 to 48 hours after birth. In neonates with Hirschsprung disease, this passage is delayed, sometimes taking over 48 hours, or it may not occur at all. This is a classic and early sign that prompts further medical evaluation of those babies. Then, because those babies don't stool, they have distended abdomen. abdomen may become swollen, distended due to buildup of stool and gas in the colon, which cannot pass through the aganglionic segment. The distension may be visible or feel firm upon touching of the belly, and it can progressively worsen if the obstruction persists. Vomiting is a common sign in affected neonates and may become bilious, so green or yellow in color due to presence of bile. Vomiting can be more frequent and may worsen after feeding, reflecting the inability to intestines to move fecal contents forward properly. Constipation is usually severe and presents from birth, so those babies don't pass meconium. The neonate may show signs of severe constipation even later, struggling to pass stool or passing very small pellet-like stools that, they may be either pellet-like or ribbon-like due to the narrowing of the segment and obstructed passage of the colon. Usually those babies are not feeding very well, they refuse to feed or exhibit poor sucking. Poor feeding can lead to inadequate caloric intake and finally, eventually, to failure to thrive. The serious complication of Hirschsprung disease, it may be enterocolitis. It's potentially life-threatening complication that is characterized by inflammation of the colon. Symptoms may include fever, explosive diarrhea, lethargy, and worsening abdominal distension, and this condition requires immediate medical attention. How do we diagnose Hirschsprung disease? Diagnosing of Hirschsprung disease involves a combination of clinical evaluation, radiological imaging, and definitive histopathological confirmation. Early and accurate diagnosis is crucial to manage this condition effectively. So first, clinical evaluation. History and physical examination. The initial step involves taking a thorough medical history and performing a detailed physical examination. Key points include delayed passage of meconium below 48 hours of life, persistent constipation, abdominal distension, poor feeding. Physical examination, signs such as distended abdomen, tight anal sphincter, and an empty rectum on digital rectal examination. An explosive release of stool and gas following that rectal examination can also be significant clinical finding. Then radiological imaging, abdominal X-ray. Plain abdominal X-ray can show signs of bowel obstruction, such as distended loops of bowel with air fluid levels. It helps in assessing the severity of the obstruction. Contrast enema is important here in diagnosis, when the water-soluble contrast medium is introduced through the catheter to the rectum, and then serial X-rays are taken to visualize colon. The classic radiologic finding of Hirschsprung disease is something that is called transition zone between the dilated proximal ganglionic segment and the narrow distal aganglionic segment. This transition zone is a key diagnostic feature on abdominal X-ray. And rectal biopsy gives definitive diagnosis. Suction rectal biopsy, where the small piece of tissue is obtained from the rectal mucosa using a suction device. Usually we start with suction rectal biopsy because this procedure is simple, quick. It can be performed at the bedside or even in the outpatient settings in the case when baby is discharged from the hospital. And then the tissue that is examined for the presence of ganglion cells. In Hirschsprung disease, of course, ganglion cells are absent in the mucosal and myenteric muscle part of the affected segment. If the suction biopsy is inconclusive, then the other option is full thickness biopsy that is performed under anesthesia. This provides a more comprehensive assessment of the bowel wall layers and gives us definitive diagnosis. It's important to mention that we have to exclude other causes of neonatal bowel obstruction. Differential diagnosis of Hirschsprung disease includes meconium ileus, intestinal atresia, volvulus necrotizing enterocolitis, or even functional constipation. Each of those conditions has distinct clinical and radiological features that help us to differentiate them from Hirschsprung disease. Treatment of Hirschsprung disease primarily involves surgical intervention to remove a ganglionic segment of the bowel and restore normal bowel function. The approach to treatment can be categorized to preoperative management, surgical procedure, and post-operative care. So before surgery, what is crucial? Intravenous fluids to maintain hydration and electrolyte balance. Very often babies, because of abdominal distension, they require nasogastric tube and nasogastric decompression to reduce abdominal distension and reduce vomiting. Sometimes we have to also give those babies antibiotics to prevent eventual enterocolitis. Sometimes bowel irrigations are necessary, so daily rectal irrigations can be performed to relieve obstruction and prevent enterocolitis until surgery is feasible. And then surgical treatment, the primary treatment for Hirschsprung disease. The main goal is to, as I mentioned, remove a ganglionic segment and restore normal bowel function. And pull-through procedure is the procedure that is performed most often. The affected segment is removed and then the healthy ganglionated bowel is pulled through the anus. In severe cases, or when the neonate is too ill to have immediate definitive surgery, a temporary colostomy may be performed to divert stool and relieve obstruction, and then definitive surgery is performed later in baby's life. Post-operative care, close monitoring after surgery is essential to detect and manage complications such as anastomotic leaks, possible anastomotic leaks or strictures or infection, prevention of enterocolitis, so intravenous antibiotics. Nutritional support is important with a focus on promoting growth and development. Sometimes those babies need IV nutrition for some period of time before they are able to be fed enterally. And post-operative bowel management may include stool softeners, dietary modifications, and sometimes rectal irrigation to promote regular bowel movements. Prognosis of Hirschsprung disease in neonates has significantly improved over years due to advances in surgical techniques and post-operative care. While most children with Hirschsprung disease can expect to lead healthy lives, the prognosis can vary based on several factors like length of a ganglionic segment. The more extensive and longer segment is involved, there's more complications. Then timing of the diagnosis and treatment plays a role, and presence of any complications before or after surgery. What are the complications after surgery and long-term complications after baby goes home? Right after surgery, this can include anastomotic leaks, wound infection, temporary bowel dysmotility, or enterocolitis. This is a significant risk even after surgery and requires prompt recognition and treatment with antibiotics. Most neonates recover very well after surgery, with bowel function improving over time. In regards to hospital stays vary, but typically range from a few days to a couple of weeks, depending again on the complexity of the surgery and neonate's condition. In regards to long-term complications, when the baby is discharged from the hospital, Small percentage of children may experience recurrent episodes of enterocolitis, which requires prompt, again, medical attention. Long-term management strategies include vigilant monitoring, prompt treatment of symptoms, education of parents in recognizing those symptoms, in some cases prophylactic antibiotics. Some children may also develop strictures, which is a narrowing of the bowel or adhesions bands of the scar tissue, which can cause bowel obstruction and require additional surgical intervention later on. Prognosis for Hirschsprung disease, long-term prognosis is very good. Many children achieve near normal bowel function with regular bowel movements and no significant dietary restrictions. Some children may continue to experience constipation requiring ongoing management with laxatives, dietary adjustments, and sometimes enemas. A minority of children may have issues with fecal incontinence, especially those with more extensive disease. This can often be managed with bowel training and supportive therapies. With appropriate nutritional support and management of bowel function, children with Hirschsprung disease generally achieve normal growth and normal developmental milestones. If there is any questions, please don't hesitate to contact me at neonatologyforparents.com. Thank you.